Machen here at Duke Spine Institute in Melbourne, Florida, near Orlando. We're getting ready to do our third surgery. Our patient today for this surgery is having a lumbar Duke laser disc repair, L45. He has a small disc herniation at L45 that's causing a lot of back pain. This patient has suffered with the back pain and wants to get rid of the pain, so we've determined the pain is coming from the herniated disc, and we're going to go in and repair that herniation. He has an annular tear with a small herniation, high intensity zone with inflammation, mostly on the right side, L45. Everybody in agreement? Sir, we're going to get started. This is Dr. Duke Machen, okay? That's my hand on your back. So first thing I'm going to do is numb up your skin so you don't feel anything. Once I get to where I need to go, it takes about 3 or 4 or 5 minutes max. Let me know if you're uncomfortable, okay? I'm just giving you some numbing medicine. Shot. When I say shot, I'm telling my associate to take a picture. Let's go lateral. Let's have some skin numbing. All right, so 5-1 is down there. 4-5. We need to be a little bit lower. That's what I thought. Let me know if you feel anything. A little bit there. All right, just give that a second for the medicine to work. How are we doing on our reading? Yep, perfect. All right, that's just my hand feeling around, okay? Numb. Here. So the beginning of this surgery is done with the help of a needle, basically, to map out a path that is safe to get down to the disc herniation. Shot. Let's go AP. And I need you to get those end plates lined up better. So rather than trying to navigate big, bulky surgical instruments down to the spine, we just navigate a skinny little needle. And from that, we can then direct other instruments that are useful in getting the surgery actually done. Shot lateral. Let's go lateral. That's a beautiful AP picture. You can see the spinous processes perfectly lined up. You've got a really nice spine, by the way. For the most part, everything is nice except for that one disc. So I need to see more in the back of the spine. I need you to drop the table, please. Just a little bit. That's good. Shot. All right, that's perfect. So probably a 1/5 of an inch, 1/4 inch up the table. Good. Let's see what we got there. That's the perfect view. Now let's get those end plates lined up, please. They may be as good as you can get them. It's pretty close. I'd say we can move a degree or two at most. Try to get it better. All right. That's what you should be aiming for with the table, the fluoro picture, the magnification. It's the other way, by the way. The opposite of where you just went. So take it the other way. Did you do it? Is that it? Perfect. Now lock it in. That's a nice view right there. That's exactly what I want to see. All right. That's my hand on your bottom, by the way. I'm not getting fresh with you. I just need to stabilize my hand so I can do all this stuff right for you. Okay. Shot. All right, so we're coming down to the facet joint. You feel any discomfort? Not bad? Shot. I want to be a little bit lower. Shot. You pulsing?
Yes, sir.
Shot. Shot. I'll start a little bit more lateral. Shot. Is that uncomfortable at all, or are you okay?
All right.
Shot. Shot. Up against the facet. Shot. 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 That's feeling really good. Right. Very close to where we need to be. Shot. So we're making good progress. Shot. Give me an AP. So right now we're right at the entrance to the foramen. We're just wrapping around the facet joint. There's two facet joints. You can see them superimpose on each other. That's the L45 facet joint. You can see there's a disc below at L5S1. You can see the tip of where I'm at is right at the joint on the patient's right side. All right, let's go back to a lateral view. So I'm entering the foramen. I'm below the exiting nerve root, and I'm going to enter the herniated disc right where the annular tear is. That's the advantage of the Duke laser disc repair transforaminal anesthetic approach, is that we don't have to remove bone or any of the tissues around the spine to get to where we need to be in order to fix the herniation. How you doing? You feel something there? Back? All right. Shot. The good news is we're going to be able to put you to sleep soon, okay? Now, before we do that, I need your help for one more thing. I want to make sure we're in the right spot to fix that pain you typically get.
Oh, back.
Is that it?
Yeah.
Is that what you typically get?
Yep.
All right, we're going to put you to sleep. How bad is that on a scale of 1 to 10? A 10. And is that you said that's your typical pain? Perfect. I want you to count from 1 to 100 out loud. If you get to 100, I definitely don't pay the anesthesiologist today. Nice and loud so we can all hear. You're going to feel a little burning in your arm. That's the medicine going in. All right, so folks, I didn't tell him I was injecting his disc, and he felt pain suddenly, okay? And that's his typical pain, right where that herniation is. He has a small herniation. On a scale of 1 to 10, it's a 2, okay? 99% of spine surgeons would look at it and say, you don't need anything done because it's not causing your symptoms. But that's not right. That's false. It is causing the patient's symptoms. It's just, unfortunately, that most spine surgeons were taught incorrectly that the size of the herniation determines the size of the symptoms. And that is 100% not true. That is true if you think about a herniation as being a mass, right? The bigger the mass, the more it pushes on things, right? So neurosurgeons talk about herniations as being masses. The bigger the mass, the more it pushes on the nerve. We need to decompress, means take the pressure, right? But that's not what's happening with these patients. 95% of the patients that have symptomatic herniated disc, the symptoms aren't coming from mass effect. Their symptoms are coming from inflammation effect or inflammatory effect. And that's exactly what we have here. Small disc herniation, big effect with back pain because it's inflammatory in nature and you don't need big compression with inflammation, okay? Think about a zit. Tiny, tiny little zit on your face. It hurts like heck. There's not a big mass there. It just hurts. All right. I'm going to take the needle out, leave the guide wire in. Stand by. How's he doing? Good? He's asleep. We're taking the spinal needle out. Of course, he has blue blood. Everybody that comes to Duke Spine Institute has blue blood. You see that? Seven millimeters. We're going to do the entire surgery through a 7 millimeter incision in his back. First thing I do is I take my dilator. It's going to basically spread the muscle tissue and fascia open all the way down to the herniation. Okay? Just lay still. Everything's okay. Now we're going to enter the foramen. Shot. Uh-huh. Coming down. Just lay still. You're doing good. So our patient is kind of in that twilight where they're not quite asleep. They're kind of in between. And we want to not put them too asleep, otherwise they stop breathing. So our anesthesiologist is walking a tightrope, a fine line, right between too much asleep where they stop breathing and that's bad, or too light where they're actually responding. Let me know when I can proceed. Yes, no, maybe so. Oh, he's going to feel it, I think. Yeah, he's moving. So I'll just wait till I get the green light from our anesthesiologist. I want to make sure our patient is comfortable enough to do the surgery. We're right on the herniation right now. Yeah, he's still trying to get away from me. Huh? Let me know when you're ready. Any questions from our audience?
None so far.
Okay. This morning we had a couple of thousand people watching. We didn't hit the big numbers that we had the other day, but you know, I think Facebook wants us to give them some extra money in order to give us more views, but you know, it's exactly. It's research and education. I'm giving them business. Anyway. Shot. That's it. So we're making our way into the tear. You guys see that black line? That's the guide wire, and then just where it meets the tip of the dilator, there's a little black wisp. That black wisp is an annular tear, a tear through the annulus fibrosus in the back of the disc, and it is extremely inflamed, and that's why this patient is suffering so badly, because they are having a lot of discomfort coming out of that tear. Shot? So we're going to go in there and see that tear with the endoscope, and we're going to repair it. And the way we repair it is by debriding it, getting rid of all the inflammatory junk that's keeping it from healing properly. And we're going to remove any herniation that may be irritating the nerve or pinching the nerve, which most of his problem, as I told you, really is back pain. It's not really so much leg symptoms. Shot. So now the tubular retractor is coming in. Shot. All right, now we're in. So I felt it go easier there. That's because, shot, that's because it went through the tear. So we're actually not harming any of these patients with this surgery, even though we're using a hammer. I made a cut in the skin, 7 millimeters. You see that? That's the only thing that we're actually doing that's going to damage the patient in any way, is that incision. And that incision is about 1/3 to 1/4 of the incision that most doctors make to fix a herniated disc. So we're already the smallest incision. We're not damaging the muscles or the fascia, and we're going right in where the herniation is. Every other surgeon that does disc surgery is either doing a fusion, artificial disc, or a microdiscectomy. All of those are extremely damaging surgeries to the body. So this is the least invasive surgery in the world to fix a herniated disc. By the way, the cervical laser we did earlier is already ready to go home. We're going to go check on him in a minute in the recovery room, but he was happy and getting ready to go home. So this is not the right grabber. This is kind of short.
Yeah, grab for the third piece.
Laser? No, let's wait. Let's use that. Let's go with the laser. Are we on 30?
Wait, stand back. I'm sorry?
Just wait. But I just don't understand how we got a short one in here. So this disc herniation right here, I can already tell you it's been around for a little while. See the gold coloration? That's calcium deposits inside the herniation, inside the tear. Those calcium deposits happen from inflammation, and not just any inflammation, but chronic inflammation. So you have to have inflammation going on for a while, usually for years, before you get that. So this patient's tear has been inflamed for, I would guess, at least a year, maybe longer. Just looking at the calcium, you can tell it's not a fresh herniation, something that happened a month ago. If it was a month ago, you wouldn't see any of that calcium. Now, people do get a herniation, and then they get a second herniation and a third one all at the same spot. So it could be that the original tear and herniation was a long time ago, was asymptomatic, or didn't cause much symptoms for this patient. They got over it quickly, and then they re-injured it recently. That happens quite a bit. We see the same stepwise progression occur with vertebral body compression fractures. Somebody will fracture their bone in their spine, and then it'll heal partially, it'll feel better, and then they'll fracture it again a few months later, okay? And those repetitive fractures, each one causes more and more damage to the spine with the collapse of the bone. So each herniation could cause more and more damage to the patient. All right, the blue dye is the blue dye we injected earlier. It's staining degenerated disc material. I'm going to pull this out. All right, well, there's the tear right there. You see it? And we're going to debride it. This is the only way to get it to heal. I remember the first time as a surgical resident at University of Florida in Gainesville, I was on the plastic surgery service. That was my first rotation. And I had a plastic surgeon who was the chairman, Dr. Caffey. Dr. Caffey, he was an older surgeon, probably in his late 50s, early 60s. I was just a young whippersnapper. Just finished medical school at USC, was moved across the country to UF in Gainesville, really excited about neurosurgery there. But they don't start you in neurosurgery, they put you in other surgical specialties first, your first year. So I spent a year in internship, they call it, learning how to do all kinds of other surgeries, including plastic surgery, ENT, heart surgery, etc. So I was on Dr. Caffey's service with him, and I remember the very first time he said, "We're going to surgery." I said, "Oh, goody. What are we going to do? A boob job? A nose job? What kind of plastic surgery are we doing?" Because I thought it was kind of cool. I was going to get to do nose jobs and boob jobs, butt jobs. He said, "Well, you'll see when you get there." He was a prankster. So we get to the operating room. I walk in. He says, they say OR6, Dr. Caffey, OR6. I go to the operating room and I open the door, and there's some guy laying on the table with his belly like filleted open, and just a big gash where his wound just popped open. And I said, "Oop, I'm sorry. I thought I was in plastic surgery. I guess I'm in the wrong room. This is general surgery." And they said, no, this is plastic surgery. And the next thing that happened was the smell of rotting flesh hit my nostrils. And I'm telling you, it smells bad. Like meat that you forgot to put in the refrigerator, and then you went on vacation for a couple of weeks and you came home and that meat's still out on your kitchen counter. Imagine how that kitchen's going to smell. Oh, yeah, and you turn the air conditioner off to save money during the summer. Okay, that's what it smells like. That's a dehisced surgical wound. So when surgeons make incisions on the body, they cut the body open, and somebody gets a problem like an infection, the incision doesn't close properly, and it just pops open. And so you have to go in and you have to clean the edges with a bovie and cut back all the dead skin, all the dead tissue, the dead muscle, the dead fat, the dead skin. You literally cut it out and throw it in the garbage. And now you've got fresh bleeding skin. That's called a debridement, okay? And plastic surgery, you do a lot of debridements. You don't get to do nose job and boob jobs. That's just in private practice. But in academic world, it's debridements, and it's really nasty stuff. So I learned what a debridement was that very first day of my surgical internship. And I'm glad I did, because it really shaped how I thought about spine surgery and fixing a herniated disc. What I'm doing right here is the same thing. It's a debridement. I'm getting rid of the grungy, inflammatory scar tissue that's keeping this disc, this herniated disc, from healing. And it's the fact that this grungy tissue is sitting here constantly inflamed because the body wants it to heal, but it won't heal, and it's causing a lot of pain for this patient. This is how herniated discs cause pain. It's inflammation. Inflammation where the tear is, okay, and that tear is trying to heal. Whenever you tear the body, it always wants to heal the tear. Think about it. If you tear your eyeball, it wants to heal. If you tear your skin, it wants to heal. If you tear your anus, it wants to heal. If you tear anything, your mouth, your lips, whatever, it tries to heal back. But if there's something that keeps it from closing up and healing, it's going to just be like constantly painful to you because it wants to heal, but it can't. There's something blocking it. Well, what's blocking this annulus from healing is the jelly in the center that squeezed out through it when the tear happened. That's called a herniated disc. It's the nucleus pulposus. So I got to zap away all this little nuclear material here, this blue stuff, in order to allow the tear to heal. And once I'm done with this debridement, and I'm the very first person in the world to describe this, folks, nobody in the world has debrided a disc herniation. I figured it out years ago. This is what you had to do to get the disc to heal and to get rid of people's back pain. Isn't that crazy? I like to say little old me, but I'm not so little. Kind of a big guy. Anyway, it's this debridement that makes this surgery work. And it's the only surgery in the world that there's a debridement. I need 8 minutes, and we'll be done. We'll be done in 8 minutes. We're doing a single level here, correct?
Yes, sir.
And apparently the next patient decided he's ready. So we're going to get him done quickly. All right. 8 minutes. You see the clock on the wall? I'm giving you 8-minute warning. So can we get this